Hi, good afternoon, everyone. Welcome to our webinar Wednesday. Today's webinar is an integrative approach to breast cancer with Dr. Tara Scott. My name is Amy Paoletti, and I'm a member of the Dutch Education and Marketing team. And I'd like to once again thank everyone for joining us today. We really appreciate all the support for the education that we've been doing all year long. I'd like to invite any of you who've connected with us today, any of you healthcare providers who don't currently have an account with Precision Analytical, but maybe would like to join our team, definitely contact us through the website, Become a Provider. We've got a great, terrific opening order that we offer all new providers where you can receive up to 50% off on up to 5 test kits. So a great way to test us out. See what kind of hormone health results we can give you and how you can work with your patients. Wanted to let you know we've got a few housekeeping items today before Dr. Scott starts. I want to let everybody know we'll try to answer as many questions as we possibly can. We'll do that at the end of the webinar. You can send your questions through the questions section on the side panel of your screen. Also, I just want to let everybody know if you need to jump off or you have some technical issues that we can't resolve, we are recording this webinar. It will be available 24 hours post-webinar. We'll also send you all the presentation slides as well. So let me go ahead and start my introduction of Dr. Scott. I've been fortunate enough in my career to cross paths with Dr. Scott for probably over 15 years now. I think we were just talking a little bit of the history that we have of knowing each other. Dr. Scott has been in the front of audiences since she was the president of her speech team in high school. This evolved into educating the community on hormone therapy, having taught doctors on 5 continents about integrative approach. She lectures around her community to raise awareness about wellness and preventative health for patients. Having watched people suffer for years with little relief after many visits to multiple healthcare providers, Dr. Scott knows how exhausting this can be. She has lived it as a patient and seen the benefit of finding answers to the core issues. Speaking helps her reach more people in less time, helping them conquer chronic health issues. Dr. Scott's humor and analogies make complex health concepts easy for the audience to understand and put into action to enjoy optimal health. She's the mother of 3 college-age children, which we were just talking about, enjoys running half marathons in every state and traveling and being active outside. So welcome, Dr. Scott.
Thank you, Amy. Thanks to Mark and all the staff at Precision Analytical for the education that you do for providers and for patients. It's invaluable, and I'm just so excited to speak about this particular topic because this is, if you had asked me one topic that I feel I need a megaphone for, and it is breast cancer. And it's very fitting that it is Breast Cancer Awareness Month this month. Specifically, I'm gonna go through these things and tell you why I feel like we are not doing a good job with breast cancer. We should be focusing more on prevention than early detection. So that is kind of my message today. So what we're going to discuss is we're going to review the physiology of the hormones specifically as they pertain to cancer. And I'm just going to briefly give you my interpretation of the different types of testing and what I use to look for what question do I want answered by what test I'm ordering. I'm going to review estrogen metabolism just briefly as it relates to cancer. And then what I really wanted to hone in on is what does the evidence say about HRT and breast cancer? And at the end, we're going to also talk a little bit about the SNPs that I feel are important at looking at in a breast cancer patient. So as Amy said, my passion is educating and speaking, and so I'm thankful to be able to do that with you all today. So one of the reasons why I'm passionate about this is my genes are really bad. I'm like a 3 out of 4 mutation at MTHFR, which according to Ben Lynch is very unusual. And my genes are really aimed at not getting rid of estrogen correctly. I've got the SNPs of the 1B1, which is not what you want, to go along with the slow COMT. So for me, I have no personal history of breast cancer in my family, but my genes would say that I'm a setup for it. So that probably is one of the reasons why I'm interested. But more importantly, it's all the patients that have been affected from that. And specifically this particular patient, Laura, who is my friend, and unfortunately passed away last year at 33 with breast cancer. So I always like to dedicate, any education. She worked tirelessly at educating patients and providers and speaking about her journey whenever she could. We did an event together, a couple events together locally. And so I really want this to be in her memory. And so as we look at how the hormones are, we can see that prepubertal, we don't see a lot of hormones. And then, as you're starting to ovulate, you start getting estrogen going up and down. During your reproductive life, progesterone is actually what's the highest, and estradiol is a little bit lower. Now, coincidentally, in the perimenopausal years, we start to see the breast cancer incidence go up at the same time as progesterone seems to go down. And during that time, you have a very erratic amounts of estradiol due to the increasing gonadotropins. So clearly there's a correlation between hormone levels and breast cancer. So the latest statistics that I saw, 1 in 8 is your risk of breast cancer. And to me, it seems like that incidence is increasing, maybe because I'm getting older and my patients are getting older, so more of them are getting breast cancer. But what we're seeing now is patients like Laura who are diagnosed very young. I mean, it used to be more common postmenopausally, but I feel that premenopausal breast cancer is on the rise. The risk factors that we do know, obviously, as you get older, the risk of cancer gets older. We hear a lot about BRCA1 and BRCA2 genes. And in fact, this panel has been expanded. I think there's probably 12 or 15 genes on this panel. There's other things like CHEK2, RAD50. All of these genes are tumor suppressor genes. So what that means is if you have a mutation in one of those genes, it just fails to suppress tumors. So it doesn't have anything to do with hormone levels, and it doesn't have anything to do with estrogen metabolism. It has to do with the tumor suppression. Family history, most breast cancer patients do not have a person in their family that has had breast cancer. We know that when you have either no children or your first child after 30, that could potentially increase your risk, as well as somebody who has not nursed any of their children. Any radiation to the chest could also increase your risk. Now, I put in here elevated endogenous estrogen levels. I don't know that you would get everyone to agree with that, but I'm going to show you some data based on that. Hormone therapy is listed there. It's never qualified what kind of hormone therapy. Are they all equal risks? So we'll talk about that as well. But we do know with obesity and alcohol, those are two things that can increase your risk of breast cancer. So what exactly is cancer? Cancer is actually the failure of the immune system to get rid of abnormal cells. So there's a normal cell cycle, growth and cell death. And so when something happens that it goes wrong, that you have unregulated growth, the cell is supposed to commit suicide. And it's not supposed to have unregulated growth. So what we know is that a healthy cell will metabolize oxygen and it'll be aerobic. But cancer cells are actually anaerobic and they siphon off glucose from healthy cells. So normally what ends up happening is that the cancer itself becomes, I guess, metabolically greedy, and a lot of cancer patients actually die from malnutrition. Sometimes they die from cancer destroying the normal cells of vital organs like liver or kidneys. As a review, we know the menstrual cycle is important. Estrogen is caused from the developing follicle. 95% of your estradiol is coming from that egg each month. And then after you ovulate, progesterone is produced from the corpus luteum. This balance is very important for the endometrium, and we'll talk about why it's important for the breast cell as well. So we know that if we look at estrogen detoxification, that can be responsible for some people why they have higher levels of estrogen. So those pathways are genetically coded, and it's like a highway. If you've got a highway that's 4 lanes and now it's down to 2 lanes, you're gonna have a traffic jam. So we see that a lot with these estrogen detoxification pathways. So I don't know, type in the chat if you're an OBGYN out there. You probably recognize this book, Clinical Endocrinology and Infertility. This is Leon Spiroff, who was our guide in residency. We thought of this as our Bible. So this is our clinical textbook that is going to talk about the physiology that I know to be true. So let's see what Dr. Spiroff says. So he says estrogen causes proliferation. Progesterone inhibits proliferation, causes a decline in DNA synthesis, and interferes with the estrogen receptor. We know that progesterone downregulates the estrogen receptor. Estrogen stimulates many oncogenes that mediate estrogen-induced growth. But progesterone antagonizes this action and suppresses transcription of oncogene mRNA. So basically what he's saying is growth is from estrogen and apoptosis is from progesterone. And the next part is very important, page 624, breast and endometrial cells are similar. So just as a review, I always think of Sofia Vergara when I think about estrogen, her luscious hair, her curvaceous figure. We think of estrogen as a growth hormone. It promotes body development. We know it's good for your bones. There are 3 types of estrogen. We know estradiol is made from the developing follicles, good for your heart and your bones. Estriol is a metabolic byproduct of both estradiol and estrone. It's not really produced in major quantity unless you're pregnant, but we know there's a special, like a good predisposition for your skin with estriol. And estrone, I hate to say anything endogenous is bad, but it has a higher predisposition to go to the breast. So if I had to call one of them a bad one, it's that estrone would be. So if we look at the 3 types of estrogen, estrone is predominant in menopause. It's primarily synthesized through peripheral conversion from androstenedione and DHEA via aromatase. Now you can reversibly convert estradiol to estrone through 17-beta hydroxysteroid dehydrogenase. Estradiol comes from the developing follicles, so we expect that when you stop ovulating, you don't have as much estradiol. Now you can get some from aromatization and from this reversible conversion of estrone, but we expect that that's going to be the predominant type of estrogen in the premenopausal time. And estriol, again, synthesized from estrone, not very populous unless you're pregnant. So I like to think of estrogen as 3 sisters. So think of it this way. You've got Alyssa Milano here. She's the good girl, you know, she's good at sports, she's popular, she's estradiol, she's good at everything, right? And then you have, I think it's Holly Marie Pete or Holly Marie Combs or something. Sorry, I don't remember her name. But you have her, see how she's kind of like real weak? And she might just be kind of artsy. She's not really bad. She's just kind of weak. She's hiding behind her sister. And then you have Shannon Doherty in the middle here. She's kind of like the badass, you know, that's what I think of estrone. Estrone in the wrong quantity, in the wrong environment, could be the sister that's going off and wearing black eyeliner, being goth, and smoking pot. So you got to keep an eye on that one. Quantity matters. It's not just as far as which one does what. So not all estrogens are the same. There is an alpha and beta receptor in every cell in our body. We know that because whenever anyone gets diagnosed with breast cancer, that's the first thing they do. They get alpha and beta receptors and HER2 new receptors. So we know that the alpha receptor is associated with breast cell proliferation, and the beta receptor is thought to be as far as breaks. So A accelerates, B breaks. So estrone has a higher affinity to bind the alpha receptor with a 5-to-1 ratio. So what that means is if it has the choice to accelerate or cause the breaks, it's going to choose the alpha receptor, while estriol favors the beta receptor. So this is a really important chart. It was published in Menopause, and so this looks the 2 receptors here. And so 17-beta estradiol, you can see, has an equal affinity to the alpha and the beta receptors. You can look here at estrone is weaker, has a higher affinity to the alpha receptor, and estriol here is the weakest, but a higher affinity to the beta receptor. And of interest, we'll come back to this, you can see these other metabolites here are much, much weaker when compared to the parent compound. And looking at tamoxifen, how much weaker it is even still. All right, so here's the problem in the US is you can also have other sources of estrogen. It can be coming from our environment, from additives, from plastics, from preservatives. So that's part of the problem as well. And then also, if you're someone, like I mentioned, that doesn't get rid of estrogen. So the first thing we want to know is, do you have high estrogen? Do you have estrogen dominance? Is it in balance with your estrogen and progesterone? And the second thing you want to think about is why. Is it because your body makes a lot, or is it because you're not getting rid of it? That'd be like if you came to me and you were bankrupt, I'd want to know, are you not getting paid enough? Are you spending too much? Or are you charging on your credit card and you're not paying it off? Those are important things. You could maybe not be spending much, but not making enough. So that's important for us to find out about anyone that has a condition of estrogen dominance. So just real briefly, the functions of progesterone. We know that in your body, it serves as an antidepressant. It helps use fat for energy, helps your thyroid function correctly. There have been some report that it stimulates bone building and also has some function in maintaining libido and sexual desire. We do know for sure through its agonization of allopregnanolone of the GABA receptor that it can promote sleep. Helps with memory as well, but I really feel that it protects against fibrocystic breast disease, and I feel anyone that has fibrocystic breast disease has estrogen dominance. So I believe it protects against endometrial cancer and breast cancer. We're going to show you those studies. There's some people that say osteoporosis and heart disease and prevents cognitive decline. We always think of testosterone as people like this, totally ripped, but you know, testosterone has other functions as well, and we'll talk about how androgens play into breast cancer as well. Of note, whenever you see someone who's all jacked like this, what happens to their breasts? Do they get actually bigger breasts from testosterone, or do they have atrophy? Usually what happens, right, is they have breast atrophy. So testosterone is really not stimulating to the breast cell. It has the opposite. Otherwise, men will be walking around with boobs. And when people do have man boobs, it's not because they have high testosterone, it's because they have high estrone. All right, so all the types of testing that we do all give us a different little glimmer of estrogen and its detoxification. And the reason why everything has a different way is because think of it as your house. Imagine I'm a census taker. It's the year of the census, okay? And say you came to my house, you came in the living room and you said, check, there's 2 people that live here. You saw my husband and I in the living room. Well, you would not accurately have counted our family because maybe my daughter's up in her room, FaceTiming her friends all night, and maybe my son is in the basement and he's playing video games, and maybe I have one away at college. So you have to look in different rooms of the house, just like the body. There are different compartments. Blood is going to show us one thing, urine is going to show us another thing, saliva is going to show us another thing, stool is going to show us another thing, blood spot testing. So, you know, you got to know the difference between all the types of testing and know the question that you're posing. Everything is a great testing. So everyone's most familiar with serum testing. All the studies have been done on serum testing. It's what's traditionally accepted. Any hormone that is large is going to be the best way to see it in the blood. When you're looking at FSH, LH, those are peptide hormones and gonadotropin hormones, and thyroid, those are large. Blood is the best place to look for those type of testing. You can also measure other things like your glucose, your cholesterol. So it's great to look at your vital chemicals there as well, and it will require a blood draw. So when I think about a blood test, I think about maybe looking at the difference between bound and unbound. We know that hormones circulate attached to proteins, specifically sex hormone binding globulin, thyroid binding globulin. So it would be as if, you know, a hormone, like if I was handcuffed, I wouldn't be able to type. Or better yet, it would be like my 401k. My money's going directly into the 401k from my paycheck. I can't get to that. So I have it, I just can't use it for later. So the bound hormones are there, but what you really want is your cash that's liquid. So the free, when we're talking about certain body functions, it's important to know what's free and able to agonize the receptor. So I think of serum testing as my bank balance. It tells me at that point in time what is in my blood. So for somebody who's still cycling, we tell them what day of their cycle to go. If we want to look at ovarian reserve, we look at it at the beginning of the cycle. If we want to look at luteal levels, we tell them specifically what day to go. So we can make some meaningful interpretations from this. But if I'm getting my bank balance, what happens if the very next day I have to make payroll? It's going to go down, right? So you got to know too, when you're talking about a hormone and when you're talking about if you're giving someone something, that may affect what time you get the blood drawn, how you're going to get the blood drawn versus when you dose to hormone. So it can be confusing. Now, saliva testing has been advertised because it's free levels. When you spit, those proteins are released and the hormones are there. And so for some time, it seemed to be the gold standard to measure cortisol. And so I find saliva testing to be helpful too. I feel that it is a good way to measure the peripheral conversion of estrone, DHEA to estrone, because that's happening in the periphery. But there are some problems with saliva testing too, because if you're treating someone, certain of the hormones have a high affinity for the saliva, like progesterone. So when you're using topical hormones, a lot of times we want to do saliva testing, but there could be some wonky things that come up here and there. Depending on who you talk to, it may overestimate certain levels and may underestimate certain levels. So I think of it this way: if I'm looking to see if my estradiol is changing into estrone, I've got to see what happens. So for example, let's just say this is my daughter. Okay, it's not my daughter, it's Katie Holmes, and she's in sweats. But let's just pretend this is a picture of my daughter on Friday night. She leaves the house in sweats and says, "Mom, I'm going to go to the library." And I think, oh my gosh, she's such a good kid. She's going to study on a Friday night. And what if she gets to her friend's house and she changes into this and goes clubbing? I am not going to see that because it's not happening in my house, right? It's happening in the periphery. So for me as a gynecologist who is interested in looking at breast cancer risk, I want to know about this conversion to estrone. So I like to see that sometimes in the saliva. Urine is another great testing, and one of the things I love about urine is you're getting kind of a whole picture of the metabolism. And so we need to know in breast cancer patients, or like I said, anyone with estrogen dominance, is the problem estrogen metabolism? So it's really important. And even so, some providers say every patient who's being treated with hormone therapy, whether they had a problem with estrogen dominance, at some point you should measure urine metabolites to see, is their estrogen metabolism optimal and efficient? So I like to think of it as receipts. If my accountant is doing my taxes, I have to tell him specifically how much I paid on payroll, how much I paid on rent, how much on advertising. He just doesn't want to know what my bank account is. He needs these details of how I spent everything. And that's like the urine testing that tells us specifically about estrogen metabolism. You know, we'll look at some of these in our case studies today, but specifically we can look at the different types of estrogen. And this pie graph makes it very easy to see visual as far as the different types of metabolites. And so that's a plus about the Dutch test. It's going to look at phase 1 and phase 2. So when we're talking about detoxification, phase 1 is generally a hydroxylation. So you've got 3 enzymes that are part of phase 1, and then you have an intermediate metabolite. And then phase 2 in the example of estrogen is methylation. And so from there, you're going to go into the waste from there. So healthy estrogen metabolism does depend on how those enzymes are genetically coded, but it's highly influenced. It can be induced or augmented by other things like nutrient levels, different supplements, vitamin levels, your healthy intestine. Your healthy intestine also is, you know, if you had a high beta glucuronidase, you could send that estrogen right back into your system. And so insulin resistance and other nutrient deficiencies can also affect your estrogen metabolism. So those are all the things that need to be working to get this all to be optimal. So when we look at specifically estrogen metabolism, we're looking at this bottom right-hand corner here. These are your estrogen metabolites. So it looks like this. You've got estrone and estradiol, and here's that reversible 17-beta-HSD. Now, estrone can be sulfated to estrone sulfate, and then you've got these 3 pathways. So if I simplify it, it looks like this. 3 pathways right here. You've got your 1A1, your 3A4, and your 1B1. Okay, now 1A1 would be the green, you got 3A4, that's the blue, and you got 1B1, which is the red, because this 4-hydroxyestrone can go down this pathway and become a quinone, which is carcinogenic. Now, good news, you have this back door here of glutathione that can give you one last out. Specifically, what we want to make sure we do is prevent a negative estrogen burden. So we've got the 1A1 and 1B1 in this particular example, and here's your COMT enzyme. If it doesn't go out that way, it's going to come down this quinone, and then you got this second chance of the glutathione transferase here. And if that doesn't go, then you have the red that can cause DNA damage and the green that can foster DNA repair. It's much easier to increase the 2-hydroxy pathway than it is to reduce the 4-hydroxy pathway. What we want to do is increase 1A1, support COMT, increase quinone reductase, and increase glutathione conjugation. At the same time, we can try to reduce 1B1, reduce peroxidase activity, as well as beta-glucuronidase. So resveratrol is something that I like to use because that can actually prevent the depurinating adducts, and it shows in human breast cells. And so it also increases NDPH quinone reductase activity. So it inhibits that peroxidase activity. N-acetylcysteine is something else that can prevent electrophilic damage, and it's been shown that it actually reduced urinary levels of estrogen DNA adducts. And of course, calcium D-glucarate is something that can happen in the gut. Now, what works right here at 1A1 is DIM, usually pushes it down this pathway specifically. So which SNPs actually matter for breast cancer? Well, you know, MTHFR, and I didn't put all the studies in here, but MTHFR isn't specifically involved in estrogen detoxification, but it's peripherally involved in methylation. And so it's part of the cogwheel that if it doesn't work smoothly, it can affect COMT activity. And so COMT is, to me, I think a more significant one because it is actually phase 2 of estrogen detoxification. 2D6 is important in breast cancer because it converts tamoxifen into endoxifen, which is the active metabolite. So if you have a 2D6 SNP and you're prescribed tamoxifen, you're not going to be able to get it into the active form of endoxifen, and it probably isn't going to work as well. And that's probably why we see people taking tamoxifen and having problems because it's not really working. 1B1 is important, especially if 1B1 is in conjunction with your COMT SNP. That's when you really worry because 1B1 is an upregulation, which means it's going to go down that pathway more often. So you'll have more down this, more 4-hydroxy, and if you've got a slow COMT, you're going to get more 4-hydroxy, which is not a good thing. And so here's the other one that it took me a while to realize is this CYP19, which is your aromatase. And so in the case of Laura, she had an aromatase SNP, so she was dumping her testosterone into estrogens. And that, again, happens in the periphery. You're not going to see it in serum. So speaking of which, let's go over a case, and then, you know, we're going to get through a couple things, and we'll go over the literature and have time for some questions. So Laura was a 32-year-old new patient. The first time I saw her, she had already been diagnosed with breast cancer. She had a baby boy, and when she was nursing and he was 6 months old, she felt a breast lump. In her family, she had a paternal aunt and a paternal grandmother that had a history of breast cancer. So by the time she found her tumor, it was already 2.5 centimeters, which means, you know, it's probably been there before pregnancy. And so she was staged at 2B, and she was actually triple negative, which means not hormonally sensitive. She also had BRCA testing, which was negative, and she was told that she would have to get chemo every 2 weeks, and they wanted to give her Lupron to completely shut her hormones down. So these are some initial labs that her vitamin D was good. We obviously always want vitamin D to be optimal when we're talking about breast cancer. She did not appear to have any glucose abnormalities with her insulin or glucose. Her FSH and LH, you know, with Lupron, I wouldn't think the FSH would have been that high, but her estradiol was definitely suppressed, as was her estrone. And here we can see her testosterone. It's red is less than 80 at this lab, which doesn't make sense because it should be the normal level could be somewhere in there, but her dihydrotestosterone was not elevated. So this was her Dutch test that she actually did after her first round of chemo was done. but she wanted to do this test. I was curious as to how it would come out because knowing that she had been on Lupron, which is, remember, suppressing the gonadotropins, so it's trying to get everything to suppress the ovaries. So of interest, she's in her 30s and her DHEAS here is low. And again, we talked about testosterone. Her testosterone was not high. She insisted on having her tumor sent out, and it later was found to have a testosterone receptor on it. It's not something that's normally checked on breast cancer, but her tumor was androgen sensitive. So looking at her estrogens, they're all going to be low because she's on estrone. I ran the test because I didn't know if it would still reflect her estrogen metabolism. Now, with this, sometimes when you have very, very low levels of estrogen, you might not really get an effect of how the estrogen metabolism is. It would be kind of like saying, I want to see your spending patterns and you're somebody who doesn't have a lot of money. You're not going to be very frivolous. You're not going to get your nails done or go out to eat and when you don't have a lot of money. But say you had a lot of money, you might be someone who shops a lot but buys designer handbags, or maybe you're someone who likes to travel. We wouldn't be able to see those characteristics until you had money, your spending patterns. So sometimes when everything is so low, it may not effectively look at that. But even nevertheless that, look how it says that her methylation index is low. So this reflects the COMT activity. And that was what one of the things that I wanted to find out about her. Here's the other thing. So there are studies that show that a flat cortisol curve in a breast cancer patient is a poor prognosis. And so we can see here that based on her total DHEA, she's in her 30s, so 1300, so that's a little bit on the low side. And you can see that she's favoring more cortisol, but her cortisol is pretty low most of the day long, and cortisone is lower too. So that is not something that we want to see on a patient with cancer. We went ahead and did do some genomics on her and found that she's heterozygote at MTHFR 677. She was negative at 1298, and she was a slow COMT. So to me, I think that might have had something to do with it. And there are some people who think any kind of methylation problems contribute to any kind of cancer, not just breast cancer. So that was an interesting look at the Dutch test, even though she was a triple negative patient. Now, Laura she tried everything. I mean, she was under the care of a naturopathic doctor, allopathic doctor, nutritionist. She did everything. And unfortunately, after her initial remission, her cancer came back and it just was so aggressive, and she passed away just 2 years after her diagnosis. So this is another interesting case. This is Amy, another patient of mine that was diagnosed with breast cancer at age 31 in 2009. So she had a lumpectomy, chemo, and radiation initially. She had a recurrence in the contralateral breast, which is very unusual. Usually it doesn't recur in the other breast, it will recur somewhere else. And so at that time, she had bilateral mastectomies and reconstruction in 2012. So she was placed on tamoxifen, and initially they told her 5 years. And while she was on tamoxifen, she had really heavy periods and a lot of hormonal symptoms. So the first thing that I did way back in 2012 was a salivary test. So sorry for this grainy appearance, but you can see that she did in fact have estrogen dominance. So of note, again, she had low DHEA. So is there a correlation with that as well? Her morning cortisol was on the low side, her night cortisol is on the low side, but she clearly had estrogen dominance. So, type in the chat, what do you think? Do you think it is more important for her not to take any hormones or to take progesterone? So this is the conundrum that we're faced here. So here's a patient who this particular hormone balance puts her at risk for breast cancer, right? Because we talked about estrogen causing proliferation and progesterone inhibiting that. And so here she is on tamoxifen, and everybody says, oh, you're fine, and let's not worry about your hormone levels. All right, well, this is the next year, 2013, different type of lab, salivary testing, but look how high her estradiol is. Look how high her estrone is. And even estriol, it's not marked as high, but usually when it's higher than 70 at this particular lab, this tells me that she's having a problem with her estrogen detox. Now, she wasn't on progesterone, and that's why you occasionally get these weird levels, and that's one of the reasons why salivary hormones are criticized. Now, her progesterone looks okay. I'm sorry, her salivary cortisol looks okay, and here's that low DHEA again. All right, so this is back in 2014. This was before the Dutch test was available. We did an estrogen metabolism test on her, and you can see that she had actually a high 4-hydroxyestrone, but she had very low 4-methoxy. So clearly there's a COMT issue, phase 2 detoxification with her. She's got high levels here, and low on her phase 2 metabolites. So let's go back and remember. Now, tell me, who do you think is going to win out at the receptor? If you have estrone in excess and estradiol, and you've got tamoxifen in the mix. Here's tamoxifan's receptor affinity, here's estrone's receptor affinity, and here's estradiol. Who do you think is going to win out at the receptor? And so that's the crazy thing. It's like saying you have a football team and I'm going to send 2 skinny cops to get them to you know, if they're getting riled up at a party or something, and you're going to send 2 little tiny little cops to calm them down. That's not going to do anything, right? These big guys are just going to steamroll right over them. So I couldn't find the levels to put them in the presentation, but I remember having serum labs for her of estradiol that were in the 500s and not mid-cycle luteal. So the luteal estradiol should only be about 200, 211, depending on the lab. And her luteal was crazy high. So I remember calling up her oncologist saying, I'm very concerned that she has these very high levels of estradiol. And they said, she's on tamoxifen. It's blocking it. Well, tamoxifen isn't 100% blockage. She's still having periods. So obviously estrogen's getting in the uterus and she's still having symptoms of breast tenderness. So we kind of took things into our own hands here. So this was 2016, another salivary test on her, still with really high estrogens. She is making progesterone, again, low testosterone, and her ratio looks okay at this point. She's still cycling. And finally, in 2019, we have her Dutch report. All right, so again, interesting that she has a low DHEA, and she doesn't have high testosterone here. So remember there were some reports of high testosterone premenopausally. So she's got crazy high estrogens across the board. And if we look at her estrogen metabolism, she does have a fair amount of her 2-hydroxy. She doesn't have too much at the 4-hydroxy, but she's got a problem here at phase 2, which is her COMT. So that's a problem. And the sheer fact of how high all the estrogens are another problem. This was her urine test. And so remember, at first it was okay. Her cortisol is looking a little worse at this point, and her total DHEA. So I'm wondering if anybody would treat her with DHEA, and if anybody, you know, obviously we're going to support her estrogen detox, but I wonder if anybody also would treat her with progesterone. So we can answer those questions in the chat at the end, in the Q&A. So the big question is, does HRT contribute to breast cancer? That's what patients want to know, right? So it all started in 2002 when everything went on the headlines, HRT linked to cancer, you know, and there was no designation of what type they were studying, what dose, anything. Everybody panicked. And I would say if you polled 10 family physicians now, they would still say hormones cause cancer. If you polled 10 gynecologists, I bet you 7 of them would say hormones cause cancer. They don't understand the literature. So this WHI study was done to get primary prevention of cardiovascular disease. So they had a randomized placebo-controlled trial. The average age was 63. They used Premarin and Provera, which is conjugated equine estrogens, and medroxyprogesterone acetate. For each 10,000 women, what they found is there were 7 more heart attacks, 18 more DVTs, 8 more strokes, 8 less breast cancers, 8 more breast cancers, 8 less colon cancers, 6 less hip fractures. And in this, about 97% really had no events. Okay, but what happened? Were any of you guys in practice when this came out? I know I was, and I know our office got flooded with calls because before anything was published in our Green Journal, which is our Journal of Obstetrics and Gynecology, it was on Good Morning America. So it was highly publicized, and everyone went cold turkey off of their hormones, whether they had ovaries, didn't have ovaries, they were 40, whether they were 60, it didn't matter. So it was a little bit of hysteria. So I think the conclusion of the study was wrong. And we know that early start has since been heart protective. And I think the hormone preparation used, we'll find out that you cannot say the risk is the same based on the different types of hormones. You'll see that there's a different risk oral versus transdermal, and also the difference between progestins and progesterone. So this was a study that was published 10 years later saying, oh, in these patients that did have breast cancer in our study, there was more commonly node positive breast cancers. So this was also 2012 and an OBGYN news on the same issue of this newspaper. On the left said estrogen alone cuts breast cancer, and on the right said estrogen alone increases breast cancer. So if those articles are both on the front page for gynecologists, how do you think family practice doctors and how do you think patients are going to weed through the conflicting messages? So on the left, you have the Lancet Oncology. That was a study that was published in May of 2012. But guess what? That was data from the WHI. So you'll see here that the data from the WHI keeps getting repurposed, republished, and recycled in different articles, but the same data. So in this study, in the estrogen only arm, they did not see an increase in breast cancer in this study. Now there were 16,000 women total. I don't know if it was half that were in this arm, but in that particular study, they did not show an increased risk of breast cancer. However, on the right-hand side, you have the Nurses Health Study, which had 121,000 women, so much more women, and ages 30 to 55, so a more appropriate age range. And they saw that there was a 22% increase with breast cancer after 10 to 15 use. And if you used it for longer, so the longer you used estrogen only, there was an increased risk of breast cancer. So this is important. Even though this particular study is before the WHI, I like to put it in here because it talks about the pathology and the histology. So they did a study on women who were getting breast biopsies, and they were getting them specifically in the follicular phase, so there was no endogenous progesterone that was being produced. They had them put progesterone gel on their breasts. Some women took estradiol gel and progesterone gel on their breasts. Some women had estradiol only gel on their breasts. And what they found is that progesterone gel on the breast cell actually decreased breast epithelial hyperplasia. So what it did in the uterus, it actually did the same thing to the breast cell. And then indeed, estrogen caused proliferation. This particular study was a French cohort, and it was looking specifically about hormone therapy and breast cancer. And basically what they said is we were unable to detect an increase in the relative risk of breast cancer. Now, in France, what was more common was transdermal estradiol and micronized progesterone. So they weren't looking at MPA. So whenever you hear a study, you've got to look at what was the preparation that was studied. You can't just say, oh, hormones, all hormones cause cancer. This one is the Campagnoli looked at progestins and progesterone. And so basically they said that breast cancer is 2 to 3 times greater in women with serum levels of estradiol and testosterone higher, and that's endogenous. And in this particular study, oral micronized progesterone did not increase the risk of breast cancer in women who took transdermal estradiol, but MPA did. This particular one said high levels of free testosterone identified as a risk factor for breast cancer in both before and after menopause, and also that preparations containing progesterone and not a synthetic progestin should be used. So this is perhaps my favorite study that I like to quote to patients. I always tell them about the WHI, and I always tell them about this E3 EPIC cohort. So this is estrogen, progestin in cancer cohort. This was not a randomized placebo-controlled trial. This was an observational study. It was women 40 to 64, and when they first published it in 2005, they had 55,000 patients. So 3 or 4 times what was in the WHI. And basically, initially they saw not only is there no increased risk of breast cancer, there was a decrease of risk of breast cancer with micronized progesterone, but there was an increase with synthetic progestins. They prolonged the study and published again in 2008 with 80,000 women, and they had 4 groups. The group that took no hormone therapy was the control group. The highest risk of breast cancer was with the progestin. And in this particular cohort, most of the women chose to take transdermal estradiol, which is bioidentical estrogen. They didn't use CEE in Europe. And so people who took micronized progesterone had no increased risk of breast cancer compared with the control group. But look here, there was an increased risk of breast cancer in women with estrogen only. So in this particular study in 2009, Ken Holtorf talks about how synthetic progestins have anti-apoptotic effects. So if we have estrogen causing growth and progesterone causing apoptosis, when you give a progestin, you're giving estrogen, which is causing growth, and progestins causing anti-apoptosis, which is more growth. So progesterone, we know, downregulates the estrogen receptor, and you're not getting that benefit with a progestin. So unopposed postmenopausal estrogen from ages 50 to 60 increases the risk of breast cancer. This is, again, extended follow-up of the WHI. This was published in Lancet Oncology in 2012. And so basically what they said is elevated concentration of endogenous estrogen has been consistently associated with an increased risk of breast cancer. So here's a couple studies that are agreeing. What I'm saying is that we have to look at endogenous levels and be concerned for breast cancer. They go on to say after a median follow-up of 8 years, the use of estrogen for a median of 5 to 9 years was associated with a lower incidence of invasive breast cancer. Again, remember, what are they talking about? They're talking about the WHI. So this study is trying to say, only take estrogen if you've had a hysterectomy, and it will lower your breast cancer risk. I have a rebuttal for that. It's coming. Okay, so this Fournier, this is now looking at what is the risk of breast cancer after stopping menopausal hormone therapy. So they found that long-term, over 5 years, progestogens, so a progestogen means either progesterone or a synthetic progestin. So specifically progesterone or dydrogesterone, which is commonly used in Europe, were associated with significant increase in risk. His study said that estrogen only can be associated with an increased risk of breast cancer for more than 10 years. So we're going back and forth, ping pong, it's like, is estrogen only a risk? Is estrogen only not a risk? And so this is progesterone versus progestins. Progesterone was associated with a lower breast cancer risk. So we're getting more than one study saying that the type of progestin equals a different risk of breast cancer. And pretty clearly, a lot of these studies are saying micronized progesterone does not appear to increase the risk of breast cancer. In this particular study, this was published in 2017, so we're getting a little bit more current now. There were 14 studies, and this is showing that the risk of breast cancer varies according to the type of progestogen. Okay, yes, that's what I'm saying. They're not the same risk. In 2018, this was the impact of micronized progesterone, and what they found in this systematic review was it does not increase breast cancer when you use micronized progesterone for up to 5 years, and that there's limited evidence that estrogen combined with oral micronized progesterone for more than 5 years were associated with increased risk. But in every patient, you should counsel them that there is always a breast cancer risk, regardless of preparation, which I agree. This one looked at endometrial cancer, and the reason why I'm putting this in here again is because this is enhancing or accenting the similarity between breast and the uterine cell. So this was something that looked at endometrial cancer and the incidence in breast cancer. So again, We agree. I've shown you a couple sources that the uterine and breast cells are similar. And so last fall, this study was put out by Lancet, and somehow they did some analysis over 100,000 people, and they made this association. If the associations are casual, they predicted for each 5 years of hormone therapy use, and they didn't say whether it was progestin or progesterone, you would increase your risk of breast cancer. So everyone went, oh my gosh, breast cancer risk again. And then this statement was put out by the International Menopause Society, and the British Menopause Society said, hey, the data that was used in that particular paper are from older observational studies of formulations and doses of hormone therapy that are no longer recommended. So here's the problem. All these headlines are put out, and you got to go to the paper and say, what did they study? What was the preparation? What was the age of the patient? All right, before we move on, I want to just kind of accentuate, there's a lot of back and forth on this estrogen only thing. So what I'm going to tell you is to use your mind. I know that in one study done 18 years ago, it showed that after 5 years of CE use, there was no increased risk of breast cancer. But I want you to think about it for yourself. We've shown you data that estrogen alone increases the risk of uterine cancer. We've shown you data that estrogen acts the same in the breast, and that progesterone is the same in the breast and the uterus, and that the endometrial cell and the uterine cell are the same. Nobody would argue that estrogen alone increases the risk of uterine cancer. And I don't operate anymore, but I'm pretty certain that when you remove the uterus, you're not removing the breasts. So if you still have breasts after hysterectomy and you're giving estrogen, you should not be giving estrogen only. I know there is this one study that says there's no increased risk of breast cancer, but we've shown you what Dr. Spiroff says. We've shown you all these other studies that show estrogen alone is going to cause hyperplasia and potentially cancer of the breast. So please use your head. Many of you may already know that. So the next question I have for everybody is, do hormone levels matter after breast cancer? Because here's the thing. We have also seen studies that show endogenous levels matter. So why are we not treating hormone levels as a precursor or an increased surveillance of breast cancer like we do high cholesterol and heart disease? We don't. People have fibroids, people have endometriosis, and we're like, okay, fine. Oh, it's a surprise when you have breast cancer. I don't know why. This particular study looked at circulating sex studies. So there just hasn't been a lot of data of people that look at that. So if I had access to a research team, I would certainly conduct this study. So they looked at follicular levels. Again, follicular levels are going to be different. We're never going to see progesterone to be high in the follicular level. And again, what we're seeing is the discrepancy in the luteal. So I'm not sure how that helps us, but nevertheless, to date, there have only been 3 prospective studies to evaluate estrogen metabolites. So Mark, maybe we need to do this study here about estrogen metabolites and breast cancer risk. Because this is saying that there aren't a lot of studies. In a large EPIC cohort, they said there was an inverse relationship between progesterone levels. And so that meant lower progesterone and higher breast cancer risk. The only consistent finding to date, though, in this particular study said that there was a positive association between testosterone levels and a risk of invasive breast cancer in premenopausal women. So this particular study, breast cancer research, it was premenopausal endogenous steroid hormones. This was published in 2013. They did find luteal estradiol to be positively associated with breast cancer, but not estrone and not progesterone, which is interesting. And androgens were also associated with a moderate increased risk. So androgens keep coming up as a risk, which is curious to me. This one looked also at premenopausal sex hormone steroids in relation to breast cancer risk, and said that higher premenopausal circulating testosterone are associated with increased developing risk of breast cancer. And they also said, although a possible increased risk with higher estradiol risk for tumors diagnosed before 50. So if we think about what Dr. Spiroff says, breast and endometrial cells are similar. Breast has alpha and beta receptors. Progesterone inhibits estradiol proliferation, and tamoxifen must be present in 1,000 times greater concentration than estradiol. So when we have these patients with these crazy high estradiol and not a lot of tamoxifen, I am not comfortable just resting on the tamoxifen and saying it's going to do its job. So in conclusion, I do believe that hormone levels do affect the risk of breast cancer. I'd love to see a world where everyone with estrogen dominance gets a Dutch test to look at their estrogen metabolism, everybody with fibroids, endometriosis, and everybody has an increased surveillance as far as hormone levels. I think these patients should be identified. Everyone who you're prescribing to estrogen to should at some point, you should be checking their estrogen metabolism. And I also believe there are unequal risks of breast cancer based on what you're prescribing. Hopefully none of you are using MPA and most of you are using estradiol and not conjugated equine estrogens. So you guys can always follow me on social media. If you have any more questions, I'm going to turn it back over to Amy to see if there are any questions in the chat.
There are. We've gotten a lot of good questions. So we'll just dig in and see how far we can get. So this was kind of asked throughout your presentation, is if you have any recommended genetic testing that you do to check COMT or the SNPs.
So what I'll just say is if patients have already done 23andMe, that chip has been changed so many times. And I know there's been some studies that have shown some inconsistencies. So my preference is not to use that. That's based on ancestry data. So for a while, I know that Ben Lynch, I think he just came out, came out with a test, the actual genetic test. Now he has Strategene, which is a platform that you can run your 23andMe through, but I believe he literally this week or last week launched a test.
I believe it was last week.
Yeah, and so I would trust anything that he has. There's also a test called MaxGen that I have used. Trying to remember the name of the company. I think it's just MaxGen. So I've been in touch with them. I'm trying to get them to add aromatase to their platform and the 2D6. So hopefully, but that one does have the COMT and it has the MTHFR and it has like ones for metabolism, and you want to get the ApoE3 and you want to get some of the other ones too. So that's a pretty comprehensive one. There's also something called functional genomics, and there's some people who have that platform. And I know some people who are on the our last estrogen metabolism talk, there were people who are familiar with that testing and the platform. So that's another really comprehensive. They provide their own test and they have some kind of computer program. So those are the ones that I would trust.
Okay. Let's see, let me make sure I say this right. Is there subclinical, or if there is, subclinical circulating tumor cell blood analysis that can be done prior to commencing HRT, just to make sure there are no hormone responsive cancer stem cells circulating under the radar?
There is a Biocept test, but it's not approved for breast cancer. It's approved for cervical and ovarian, but it's not. There is something called circulating tumor cells, but that's mainly for somebody who already had cancer. So the Biocept is the lab, but if they run it, it's not indicated, not FDA approved for breast cancer.
Okay. Do you run the Dutch test on patients taking an aromatase inhibitor or tamoxifen?
That's actually a really good question. So I have done both. And so what I see is tamoxifen is a selective estrogen receptor modulator, right? So your body's still going to produce estrogen and it's still going to get in and agonize that receptor, right? So when people are on tamoxifen, you know, you can still kind of look at their estrogen metabolism. Now, I have run these tests on people who are on Arimidex, which is an aromatase inhibitor. That seems to be a complete blockage. I mean, when they're on that, you can actually see that it's not getting through. So if you have someone that you're really worried about their estrogen, even though it's, you know, miserable with the side effects, I mean, aromatase inhibitors are actually doing a better job of blocking it than tamoxifen is. But I don't know exactly what the protocol is now, but the last time I looked into it, it was premenopausal use tamoxifen and postmenopausal use aromatase inhibitor. I do have some breast cancer patients now that their doctors are having them on aromatase inhibitors, which I think is like like I said, a little bit better blockage if you really want to block the estrogen.
Okay. I think it was the first case study you showed in the example, where was Laura's tumor sent that showed the testosterone receptor positive? Did you do that locally with?
I could find out that if you get someone's name. I feel like it was Chicago, but I don't know. I could easily find out. I can't remember.
Okay,
It was not local.
Okay, I do have the clinician's name, so I could maybe hook the two of you up.
Yeah.
Okay. Let's see, what do I have here? What is your opinion of a person using black cohosh who appears to have estrogen dominance? Hang on here, let me make sure. Estrogen dominance based on urine tests and has also been diagnosed with uterine cancer. Black cohosh is usually considered estrogenic. This physician usually avoids in these cases, but has been argued that it is supportive for balancing. Let me make sure I get this estrogen. What's your opinion?
Black cohosh kind of got a bad rap when there was a bunch of contaminated black cohosh out of China, and it is considered a phytoestrogen. I don't know that we have data as far as how it is at the receptor activity, at the alpha and the beta receptor. I mean, there's always those things that circulate about soy, and then it came back that soy is not an issue unless it's, because look at all the people in Japan. So as far as black cohosh, from what I understand, it's going to moderate your symptoms only, but I don't know that it's really going to do anything for your estrogen metabolism. So I think that there would be better supplements to really support estrogen detox in someone with uterine cancer. All black cohosh is going to do, and I'm not an herbologist, but I think all it's going to do is help your symptoms. I don't think it's really going to help your metabolism.
Okay. What time of cycle do you test hormones for a premenopausal breast cancer patient? Do you still use the luteal phase day 19 through 21, or do you do anything different?
So, I mean, I also do the cycle map for Dutch as well. If there's something in the history that tells me there's a specific symptom at a certain time of the cycle. I just had a patient today that had a very specific set of symptoms at a time in her life, so I'm going to do the whole cycle map. But what we're really looking for is the estrogen metabolism, which can be captured just on the one day. And for ease of collecting it and getting it back faster, I would probably just do the one day, unless there is something else I was trying to demonstrate.
Okay. Do you have an opinion regarding iodine and apoptosis relating to increase in iodine deficiency is contributing to increasing rates of breast cancer and younger age of onset?
Yeah, so there's a lot of data about iodine and breast cancer, and iodine is a lot in your breast tissue. So there are some studies that show that giving iodine actually can help breast cell hyperplasia or fibrocystic breasts. And certainly knowing where iodine deficiency is and the correlation between benign breast disease or even breast cancer. The problem with iodine is if you give too much iodine, then you're gonna have to watch what the thyroid does. So although it is good to help, at low levels, when I first did my functional medicine training, we were recommending a lot higher doses of iodine, and now it's more on the 4 to 6 microgram level rather than the 50 that we were taught initially. So I think there is definitely a role for iodine in fibrocystic breast disease and also to keep, breast health. But I think you just have to balance that in either somebody who has a thyroid problem or, too much iodine can be a problem as well.
Okay. Do you investigate estrogen metabolism in women receiving chemo or radiation only when they have triple negative disease?
So I think anyone with cancer should have their methylation looked at. And so the estrogen metabolism isn't a complete assessment of methylation, but it's an indirect way. We're looking at COMT activity. And so somebody triple negative, theoretically, you shouldn't worry about that. I'm not saying that I say this, but the doctors will say, well, it's not hormonally sensitive. So I have triple negative patients that, that is the worst prognosis, but I have some that are healthy and down the road have chosen to take hormones with regulation and looking at their estrogen detox. So I think that it is important, I think the question is, would you check it in a breast cancer patient? I would probably check it either way. The reason why Laura's wasn't ideal is because she was on the Lupron, so it was suppressing her, and she wanted to still go ahead and do the Dutch test, even though they wouldn't let her come off the Lupron for a while. So I think it would be very helpful in either situation.
Okay, great. How do you monitor if, and hopefully I say this right, Dr. Scott, Herceptin is working, and how long does someone stay on Herceptin?
So since I'm not an oncologist, I don't think I'd be able to give you the best answer for that.
Okay. Let me go to the next one. So how long do you like to prescribe BHRT? This is more of a general question. Like, would you prescribe even for a patient in their 90s?
That's a good question. So we just, I've just had this discussion come up at the last couple conferences I've taught about. So what I can tell you is this. Initially, the WHI said 65, 5 years of use, stop it, right? And ACOG said hard stop at 65. Well, that has since been rescinded. And now they don't say to stop it at 65, they say assess. Now you fail to get an additional cardiovascular benefit over 65 and potentially osteoporosis benefit. You get those early start. That's early start for cardiovascular and bone health. But there are so many studies coming out with older ages, like the ELITE trial, showing improvement in cognitive decline or potentially decreased risk of diabetes and Alzheimer's. And some of my brain health colleagues in functional medicine prescribe and start in the 60s. So what I would say is, if you have a patient that started it early, now when you start it late, you're going to have a higher risk of either a VTE or something like that. So if someone's already been on it, would I continue it through the 90s? If they're monitoring, I make them do a functional test every year, and make sure that we're looking at the levels. And so would I start it at 65? I wouldn't. If I checked it and I consented the patient and they didn't have a history of anything, I would consider doing it. I think we're just seeing now more and more data about cognitive decline and starting. I think, I'm not going to lie, that it doesn't make me a little nervous, because we know the longer you use a hormone, that increases the risk. So but in the right patient, I think you could. And I think, the risk is the dose, the route of administration, the type of hormone used, and the duration. That's what the risk is about.
Okay. This is somewhat of a generalized question as well. Can you talk about things you look at or considerations, and you may have just sort of answered this, before starting BHRT? Do you require women to have recent mammogram and pap smears?
They are supposed to, but since I don't practice GYN anymore, I don't physically do them. So I have some patients that don't want to get mammograms, they get thermograms. So
yeah, I'm one of those.
Yeah, I'm okay with that. I think we don't have population data on that, but I think it's a very effective way of screening. So they have to go to their gynecologist for that screening every year. Whether the self breast exam and the breast exam from the gynecologist, the PAPs, they have to have per the guidelines.
Okay. So best form or types of glutathione for phase 2 metabolism in patients, what would you recommend?
So I see equally effective either giving NAC 500 and sometimes twice a day. The forms of glutathione that I like trisomal glutathione. The dose isn't super high, but Apex makes it. It tastes really good. Designs for Health makes a really good liposomal glutathione. It doesn't taste as good, but I think it's 500 milligrams. I always ask the patient, would you rather take a capsule, take the NAC, versus if you'd rather take the glutathione? So I think either of those forms are acceptable.
So I'll throw this question at you. I don't know whether you want to answer it or not. If they're asking, in the traditional cancer treatment setting, are women screened for the SNP that affects tamoxifen and metabolism before it's prescribed?
Not to my knowledge.
Okay.
My knowledge. You know what? People are getting more integrative, and I'm surprised. But I would say, at least where I'm from, no.
Okay. Let me see. Let me see if I've got one more question here. Yep, you answered that. More on BHRT and length of prescribing. And I know every patient's individual. So, okay, this might be an interesting. Any particular anything you want to offer about progesterone positive cancers and giving progesterone?
That's another really great question. Honestly, like I just started doing a literature search, but I haven't had a chance to actually read all the articles because there's this new anti-progesterone medications that are used for like fibroids. So I don't have enough knowledge to dig into that. And I do know, especially in Laura's case, she was looking into a study that was an anti-progesterone. I've had a couple conversations with Dr. Zava about that, and because he used to research breast cancer, and so basically what I was taught is that when you have your estrogen receptor and your progesterone was low, that meant estrogen dominance, and you'd want to give progesterone. So I think there are a few reported cases that if you have a progesterone receptor, does that mean if you give progesterone, you could stimulate the tumor growth? And I just don't think we know. So I haven't dug into the recent literature of the anti-progesterones. I know there's some clinical trials going on with breast cancer and those drugs, but I think that's in advanced stages. So I can't tell you the answer to that, but it's an interesting question.
Okay, so this will be our last question, and this is again somewhat broad. So, how far into when you've prescribed the HRT to a patient would you then retest with Dutch for estrogen metabolism? I know we usually recommend somewhere around a 3 to 4 month time frame, but I'm not certain what you do in your practice.
I wouldn't do it any earlier than 90 days. And of course, it depends on if someone's cycling or not.
Sure.
So obviously you want to have at least 3 cycles, whatever that may be, might be longer than 90 days. If everything was free, certainly, but sometimes it's not till 6 months just because of somebody's budget that we do the initial retest.
All right, so that's going to be that was our last question. We still have a lot of questions that we didn't get to, so I apologize to everyone, but I think it definitely demonstrates the interest and importance of this topic matter. So maybe we'll have Dr. Scott back again to kind of just keep pressing forward on this topic because I think it's interesting. I think a lot of you get faced with these patient situations, and just good to have everybody kind of work together and mentor each other. So I appreciate you being with us today, Dr. Scott.
Thanks for the opportunity, and thank you so much for all you guys do for education. We really appreciate it.
Absolutely. Thanks, everyone, for joining us. I hope you're with us in November with Dr. Carrie Jones. She'll be speaking on cortisol awakening response and autoimmune responses. So look for the promotion on that and hope to have you all with us again. Thanks so much, everyone.
Thank you.
Bye.